Welcome everyone, and here is your lecture on childhood infectious disorders and immunizations. Here are the objectives for this lecture that you can read through on your own. This slide is just a brief overview and review of what HIV is. Just to reacclimate yourself to the disease, and I'm sure you guys have discussed this in MedSurg. So truly for pediatrics, we want to discuss the effects on babies, infants, kids, how we treat HIV, and you may have talked about this in OB, but just as a reminder, infants born to HIV positive women do typically test positive for HIV antibody and not HIV virus. So remember that piece, that usually if they're tested right after birth, they do test positive, and that's because they have the antibody from the mom. This is actually a measure of the maternal antibody and not detective of true infection in the infant. Most children infected with HIV develop symptoms within the first 9 months, remember that, of life. The remainder of those infected children become symptomatic sometime before 3 years of age. And children with their immature immune systems have a much shorter incubation period than adults. That's why they typically express symptoms of HIV or AIDS sooner. So the most common opportunistic infection of children infected with HIV is pneumocystitis, carni pneumonia. So just like with adults, it is pneumonias, their biggest issue for a secondary infection, and it occurs most frequently between the ages of 3 and 6 months. With our kids with HIV, we have to remember that we still are promoting them getting their immunizations. So we do recommend they stay on a normal immunization schedule as long as they're healthy. The only one that is the exception is chickenpox vaccine, because it is a live virus. So that is the only immunization we would ask them to avoid. Otherwise, yes, we encourage parents to have their children immunized. And treatment, same as adults. We go with AZT, monitor and draw complete blood counts due to risk of anemias, but otherwise treatment is the same. So, and when we look at testing for HIV in kids, again, when we do it right after birth, usually there's positives, but that's because of the antibodies from mom. So when we look at testing for kids, remember that the only confirmation or true confirmation of HIV is done through the detection of the P24 antigen assay, a virus culture of HIV, or the polymerase chain reaction, doing testing for that. Those are the only, so star that, mark it, that you remember that those are the only ones that truly detect if a patient has HIV, because the Western blot, all that's doing is detecting presence of HIV antibodies. So that's not a clear cut that the child has it. A CD4 plus count is only checking if their immune system is working correctly. So again, not a positive test that or definitive test that a child has HIV, or a chest x-ray. All that is detecting if the child has pneumonia or some other illness related to the HIV. Again, not a definitive test if the child has HIV. And presumptive diagnosis may be made on one positive test, but to truly declare or delineate that the patient has HIV, you need to have or rule out that the patient doesn't have HIV, you need 2 negative tests to rule out that they don't have HIV. So that's how we confirm testing of HIV on our kids. So one of the most common infectious diseases among kids is chickenpox, and that's why we're talking about it first. As you can see on the slide, I've stated common symptoms that kids have. In the case study presentation done in class, they did a great job. This is a picture on the side of what the rash typically looks like. And as they stated, usually it presents itself on the warm areas of the body, so back, torso, or front, abdomen, buttocks are areas that it typically occurs. You need to remember, and I do have on here that the incubation period is 14 days, and you should have learned this in community wellness, but incubation is the interval between infection or exposure to the disease and the appearance of initial symptoms. So the incubation period for chickenpox is 14 days, meaning before these kids even break out with the rash, they are infected with chickenpox and can infect other kids with chickenpox before they even present with these signs. So that's why, like on admission at Children's, we ask if kids have been around or exposed to anybody with chickenpox 2 weeks prior to admission, because if they have, we put them in isolation because they truly can have the chickenpox vaccine and they just aren't presenting with symptoms yet. So throughout this lecture, you'll see I have lots of pictures. That's for all the visual people, and I think it's great so you know what the different infectious diseases look like for the disease process. But with chickenpox, other things to remember are that the child is infectious. Again, 14 days prior to exemplifying symptoms, all the way until their spots are crusted over. So they do need strict isolation, meaning that they need to be in contact and droplet isolation. Treatment for this is really treatment of the symptoms. So calamine lotions, as presented in the presentation, they should have oatmeal baths, anything to relieve the itching, put socks over their hands, prevent them from scratching, use Benadryl cream, whatever. The other piece is some people have heard that if you give kids acyclovir, that will get rid of the chickenpox. It does not get rid of chickenpox. All acyclovir will do, because it's an antiviral, is decrease the amount of lesions and the severity of the illness, but it does not get rid of chickenpox. So just remember that acyclovir will not cure chickenpox. It only helps to decrease the amount of lesions the child develops. And with chickenpox, kids can get them anywhere. They can even have oral lesions. So this picture is just to show and reiterate the importance of monitoring hydration with these kids. And if they do develop lesions in their mouth, which can be very painful, that you have them use lidocaine swishes to numb the area so that we still can get fluids in them and keep them hydrated. So on this slide, we are moving on to the next infectious disease in kids that we're going to talk about, and that is rubella. And on the left side, you can see the rash that is on the child's face. And then on the slide that's on the right, you can see the rash as it is on his back, torso, buttocks. So this picture, we are moving on to the next infectious disease that we'll talk about, and that is rubella. So this is a rubella rash on this child that you can see the rash on his face, and then the second picture you can see it on his trunk or torso. So with rubella, for the most part, and the other name for it is German measles, for the most part it's a pretty benign disease. Symptoms usually they just start with a low-grade fever and a mild rash that lasts 2 to 3 days, headaches. A lot of times these kids just complain they're just kind of achy, if you will. And an easy way to remember rubella is that think head to toe, head, shoulders, knees and toes, knees and toes. The rash usually begins on the face, spreads down the trunk, and then fades within a few days. So think top to bottom with this disease process and the rash. It's not related to rubeola, which we'll talk about. So getting an immunization for one doesn't mean you're immunized to the other. Key, star, asterisk, whatever you want to do, that you want to remember with rubella is that due to the teratogenic effect on a fetus, there can be severe defects in a fetus when it occurs in the congenital form. So you do want to, I don't care how you start, make sure you keep pregnant women away from anybody who has German measles, because if they get it during 3 to 4 months of pregnancy, you're almost guaranteed that the fetus will have some kind of birth defects. So that's why we, again, immunizations push them that pregnant women, anybody has the MMRV, measles, mumps, rubella, and chickenpox vaccine. So those are the main things with this slide. So this slide is moving on to pictures for the next infectious disease process we'll discuss, which is rubeola or measles. So we had chickenpox, then we had German measles. Now we're going to go over rubeola, which is just measles. This picture shows Koplik spots, and you want to remember that that they're small white lesions on the inside of the cheeks or the mucosa. They appear like grains of salt on a wet background. And diagnostic of rubeola, however, not always is seen because Koplik spots tend to be translucent and can disappear within a day of their first appearance. So just remember Koplik spots and their presence and in rubeola or measles. So this is what the rash looks like for rubeola as opposed to rubella. But like rubeola rash does start head to bottom, and the buttocks rash usually appears the third day. So with rubeola or measles, symptoms, remember the 3 C's. Typically these kids present with a cough, colds, and conjunctivitis, or it may be diagnosed as pink eye. These kids also will present and have those Koplik spots like I showed you in a couple slides ago. The Koplik spots typically appear 2 to 3 days before the rash. So the rash is the second part of it. And again, like rubella, it starts head to toe. So the rash usually begins hairline around the face and spreads down the body. It eventually turns brown, so it stops looking so red. Rubeola can be fatal in children under 5 years. And remember that the incubation period for rubeola is 1.5 to 2 weeks after exposure. The last thing with rubiola, the viral cultures are typically not used for diagnosis because diagnosis is usually simply made on clinical features with these kids. This is simply a picture of a child that has roseola rash. So this is why I gave you the handout, because it can be very confusing and frustrating trying to differentiate between rubella, rubiola, and roseola. So the last R infectious disease we're talking about is roseola. It is a type of herpes virus. With this one, main things you want to remember. With these kids, they typically have an abrupt high fever. High fever meaning like 105 or greater. So febrile seizures are very common in these kids. You want to remember that star. They're contagious already when the child has the fever, and it can spread respiratory because of the saliva and secretions person to person. So these kids are put in droplet isolation. The fever typically subsides when the rash begins. So remember, the process for this illness is that it's the fever, then the rash, and that febrile seizures are common. And the rash for this, as opposed to rubella and rubiola, where I said it went head to toe, with roseola, it goes trunk, face, then their extremities is how the rash spreads. So there's no treatment for this infectious disease also. We just encourage lots of rest and a lot of fluid. The next infectious disease we talk about, which kind of falls under respiratory too, and I really didn't cover it there, is pertussis or whooping cough. It's where they have that short whooping cough, or I don't know. Look at the video. It's a great video that I have attached here. A lot of times, like when I talked about croup and respiratory, same thing with pertussis. The symptoms typically are worse at nighttime, and usually pneumonia is a complication, and these kids can end up dying from pertussis. That's why we advocate that children are immunized against it. And these kids, because it is a respiratory infection, that we do put them in droplet isolation. This is just a picture or visual for you of a child with Fist disease. So Fist disease is a type of HPV virus. Remember that it does occur in 3 stages. So the first one is fever, runny nose, headaches. These kids typically complain of. The second phase actually is the slapped face appearance that disappears between 1 and 4 days. It may also kind of come and go. So some days within that 4-day period it'll look worse, and some days it looks better, and then it looks worse again. They have the macular papular rash or red spots on their extremities, and that can last 7 to 10 days. And the rash may be itchy, especially on the soles of their feet. And then the rash subsides but reappears if the skin gets irritated, like extreme heat, so they get sunburned or they're cold or friction, whatever. They also may have painful joints and swelling. Usually these kids get sick 4 to 14 days after getting infected, so it doesn't show up initially necessarily. And 20% of children and adults who get infected with these with this will not even have any symptoms. But also that, remember, the most contagious, it's most contagious before they get the rash or joint pain and swelling occurs. And it's spread through respiratory secretions. So if these kids are diagnosed, they need to be put in droplet isolation. But again, with any of these infectious disorders, if these kids are around or exposed to anybody else who has it, we want to keep them isolated, again, because they can be spreading it before they're even symptomatic. So the main point on this slide is that, again, we want to keep pregnant women away from kids that have this because there can be severe teratogenic effects, or if they're pregnant, there can be, effects on the fetus that they're carrying. Also, it's just FYI that it's an infectious disease because it was the fifth of the classical childhood skin rashes. So there was measles, scarlet fever, rubella, scalded skin syndrome, and then they came up with roseola, which was defined as the fifth disease. So that's why it's called fifth disease. So the next two slides are just pictures of a child that has mumps. So mumps, which typically we don't hear a lot about because of vaccinations, but still can occur. Often symptoms present like a regular cold, fever, headache, they're just tired. But then you kind of start to question, because if you see that lump like in a child, like the pictures prior to the slide, and then they start complaining of earache, pain, or it hurts when they're trying to eat or chew, that is when you want to think, oh, do they have mumps? Usually this is spread through saliva or mucus, so these kids are put in isolation, or can spread amongst the family really quickly if they're not washing their hands really well, or sharing eating utensils, things like that. Complications we want to watch for is that if they've reached puberty and have gotten mumps, is that orchitis or inflammation of the testes can occur, and they can become sterile for boys that get this. Other complications may be encephalitis, meningitis, oophoreitis or inflamed ovaries, or mastitis. But so main things with mumps is truly prevention. So putting them in isolation, not sharing eating utensils, drinking out of the same glass because it is spread through saliva, and just watching for symptoms. The next infectious disease we're going to discuss is scarlet fever. And this is a picture, again, another visual to describe where the rash begins, how it spreads. Another visual of the rash and how it spreads in the mouth, where it starts with that whitish yellowish coating on the tongue and turns to just a strawberry bright red. This is just a picture of the facial rash that presents with scarlet fever. This is just a picture of the rash that develops on the body creases when they have scarlet fever. And then typically with scarlet fever, they even end up having, because of the rash, that their fingers and their skin starts to peel. So this is just a visual of that for you. Scarlet fever usually presents itself with or as a result of strep throat. So another reason to get your kids treated if they have strep throat. Symptoms are stated here. A lot of times too, these kids have halitosis, which I'm not sure if you know what that is, and that basically is bad breath because of the strawberry tongue. And as you saw in previous pictures, first day usually they have a white strawberry tongue, then the third day they usually have that red strawberry tongue. The rash itself typically looks like a bad sunburn and then progresses to their fingers peeling, etc. This slide gives you a verbal overview of how scarlet fever presents itself. I would refer you to slide 26. Again, just as a visual, if you're a visual learner, of how the rash presents itself, beginning on the neck and face, to then going to the skin folds or like armpits. Other things you want to remember, again, that these kids typically have the halitosis or bad breath, and that usually these kids are treated with a 10-day course of antibiotics, and it subsides and they're just fine. Last thing is the desquamation is what that's called, as seen in slide 30, where there's the peeling of the fingertips. So desquamation is defined as a fine sandpaper-like on torso, sheet-like sloughing on the palms and the soles. So just remember that word. One of the last infectious disorders we're going to talk about is mono or mononucleosis, and this is just a visual of the various organs and body systems that are affected by mono. So mono, which is very common among kids, has a lot of alternative names. Again, you see the second one, mono, that's what I'm calling it. Probably most common name for it. Or the other one, aka kissing disease, because it is spread through saliva. And that's why we correlate it with people that are kissing and, exchange mucus. Can get it. Typically these kids present and they don't feel that sick, if you will, but the number one thing that they will start to complain about most is fatigue. So remember that. Then they have a sore throat, possibly strep throat that doesn't get better with antibiotics. Other main systems that are involved: swollen lymph nodes, swollen tonsils, they have a headache, skin rash, soft swollen spleen are common things. So with mono, the only way to truly diagnose mono is through a mono spot blood test. And as far as treatment, we really can only treat the symptoms. There is no cure for mono, if you will. So encouraging kids to rest, stay home from school as long as they need to, even if it's returning to school part days or part-time, until they have enough energy to be there a full day. And then truly avoiding contact sports and avoiding gym and strenuous exercise, because we want to prevent the risk of rupturing their spleen. Lastly, we'll discuss the fun stuff, which is intestinal parasitic diseases or intestinal worms. So the main or most common intestinal parasitic diseases that we see are the worms, or basically intestinal worms you see here. They can wiggle through sweat glands or hair follicles and skin when people walk, sit, or lie in dirt containing human feces contaminated with hookworm larvae. So that's how the hookworm are spread. The most common worm parasitic disease that's spread is the common roundworm, or Ascariasis, which is most common in humans, and that's contracted by eating fruits or veggies grown in soil fertilized with human feces, contaminated with eggs. If it's severe, it can do a complete obstruction of the intestines and can cause death. So that's why we do teach our patients and advocate that people wash their fruit and vegetables before they eat them. Then there's the threadworm, which is fairly common, and then Giardiasis, which is caused by a protozoan. It's the most common intestinal parasite in the United States, and it's found in daycare centers. Cysts can survive for months. Usually these kids are asymptomatic, but they can have abdominal cramps and diarrhea, and it can pass the cyst for months. So the giardiasis is the most common in the United States. Again, most common in daycares, and it's because people are changing diapers and they aren't washing their hands. How we test for worms is by doing tape tests, and I will cover that on the next slide. So as nurses, we still need to be conscientious of intestinal parasitic diseases because, like I said, giardiasis is still common in the United States. So we need to know how to prevent it and keep our kids safe. But it's also, any of these tapeworms are very common anywhere in the world, and students have seen that in Mexico. We need to remember that prevention is the key. So good hand washing in daycare centers, doing proper teaching when kids are swimming, making sure that they aren't wearing just regular diapers that stool and feces can leak out of, that they should have swimmers on, swimming in lakes, because that stagnant water can breed those spores. In chlorine, the spores are resistant, so in pools, usually if they have a good chlorine level, kids are fine. But also, we need to be aware of how we check for if kids have intestinal worms. And what we do is what's called a tape test. And what it is the parents need to put tape on a tongue blade and put it on the child's anus, or butthole, if you will, before they have a BM in the morning, because usually kids will poop in the morning. And the transparent tape is used to collect the pinworms and their eggs from the perianal area in the morning, because then when they poop, it'll adhere to that, and then the parents can send in the stool sample, and we can test for the tapeworms. So again, or the intestinal worms. So again, remember that the tape test is what is used to diagnose for intestinal worms. So moving on to immunizations, remember, be an advocate. Every child should be immunized. We just have to take into consideration those kids that might be at risk if they get immunizations. So again, asking if they've been receiving any steroid therapy, receiving any immunosuppressive therapies, if they've had any generalized malignancies, any immunological disorders. Just double checking and asking those questions to make sure that it is safe for the child to be immunized. Remember which of your immunizations are active versus passive, and remember that your active ones are long-term and they occur over time as the body produces antibodies in response to an infection or to an immunization and becomes immune as a result of the primary immune response. Passive immunity, remember, is mom to babe, where it's temporary and occurs after immunizations with antibodies, and also when it's passed between a mother and her fetus, and when transmitted to an infant through breast milk. So remember those. Also remember that most immunizations consist of killed vaccines or live attenuated or weakened viruses. Usually we do not give our vaccines to immunocompromised people. And remember that we always ask if a child has been sick or has a fever, because if they have been febrile or have been sick, we typically will hold off doing the immunizations. But if kids present and have common cold symptoms, we aren't too worried about that, and typically we'll still keep them on schedule and give them their immunizations. So this is just reiterating how much we can give kids in each muscle, which muscles we will give immunizations in according to the child's age. All of you guys receive these in your clinical folder. It's just a review. Please review it before your quiz. So, and I will not quiz you or put on your final exact dates for when kids would get immunizations, but I have included the schedule here for you, just as a guideline, and so you can reference it and see how many immunizations kids actually get within their first few years of life. So as a nurse, your role with immunizations, again, checking the patient's status, making sure they haven't been sick, that they aren't immunocompromised, they're okay to get immunizations. Be an advocate that every child should be immunized. Make sure that the parents are educated on the immunizations that the child is getting. Pre-medicate the child if you can, if that's an option, giving them Tylenol. They can have ibuprofen if they're over 6 months of age. Putting on Emla cream or topical numbing cream if the parents would like, and or if time allows. When you're administering a immunization, remember, same with adults, use a quick darting motion when you're injecting it. Use distraction, use play, get child life involved to help them distract the child. And then also when it's done, having the parents comfort the child, give them praise, give them stickers, give them toys. Cool compresses often help or give relief at the injection site to minimize pain and tenderness. And then obviously documenting the sites that you gave the immunizations and or the dosing and all the other information that you need to enter for vaccinations.